Before viewing this month's online CPD, please make sure you answer the pre-test. This is to assess if there is enhancement of your individual continuing professional development. Hi, I am Dr. Annalyn Reyes, member of the Philippine Pediatric Society, Southern Tagalog Chapter, and a pediatric infectious diseases specialist. Welcome to Ingat sa Kagat at Ano ang Dapat. This is in connection with the Rabies Awareness Month of March. I always receive phone calls from pediatricians regarding their relatives or patients with animal bites. This topic is seldom tackled during our pediatric residency. It is therefore the objectives of this lecture to define rabies, describe epidemiology of rabies, explain category of bites and management, explain rabies immunization, and answer frequently asked questions. What is rabies? Rabies is a zoonotic disease which causes encephalomyelitis in humans. It is transmitted through exposure from infected animal, and the mortality rate is 100%. Domestic dog is a main reservoir in developing countries. This is a patient in our ITM who had rabies. Rabies causes 55,000 deaths per year worldwide. There are already 250 to 500 cases in the Philippines, with a 100% mortality rate. There are already 300,000 victims of animal bites for post-exposure prophylaxis. How can a person get rabies? Usually, you get it from bite or scratch, others through lick, through broken skin or mucous membranes, others through aerosol, like for example if we're exposed in caves by bats or from the laboratory, and in some cases it is through transplant, through cornea transplant, solid organs, or vascular conduit. There are two types of rabies presentation: the encephalitic or the furious, and the paralytic or dumb. In the encephalitic, there is usually aerophobia, wherein even if you fan the patients will go wild. Hydrophobia, wherein even at the sight of just a bottled water, the patients will be very furious. There is hypersalivation. There are spontaneous inspiratory spasms. There's the presence of restlessness, aggression, hallucinations, agitation, disorientation, and other signs of CNS dysfunction. The other type is the paralytic or the dumb rabies, wherein there is lack of aggressiveness and there is weakness. This can also be mistaken for GBS. These are the laboratory diagnoses for human rabies suspects, ante and post-mortem. Usually, you can do virus isolation, antibody detection, or viral RNA detection. Post-mortem, you can do also antigen detection, viral RNA detection, and virus isolation as shown in this slide. So what is the post-exposure prophylaxis for an animal bite? The first is local wound care. Then, there should be a categorization of exposure. because we have to categorize the exposure, because through categorization we will know the management of the rabies. And then immunization, which could be active immunization or passive immunization. First is the local wound care. Wounds should be immediately and vigorously washed and flushed with soap and water, preferably for 10 minutes. Wound care is an essential part of post-exposure prophylaxis and is just as important as vaccination. So, after that, you can apply antiseptic, which can be alcohol or tincture of iodine, and you can give antibiotics for all frankly infected wounds, all Category 3 cat bites, all other Category 3 bites that are either deep, penetrating, multiple, or extensive, or located in the hand, face, or genital area. The drugs of choice are the following: amoxicillin with or without clavulanic acid, or cloxacillin or cefuroxime acetyl. For Category 1, always remember that Category 1 has the intact skin. This type of exposures are the following: feeding or touching an animal, licking of an intact skin with reliable history and thorough physical examination, exposure to a patient with signs and symptoms of rabies by sharing or eating or drinking utensils, and through casual contact like talking to, visiting, and feeding suspected rabies cases, and routine delivery of health care to patients with signs and symptoms of rabies. The management for Category 1 is: first, you have to wash the exposed skin immediately with soap and water. There is no need for vaccine or rabies immunoglobulin for Category 1 exposure, and pre-exposure prophylaxis may be considered for high-risk persons. For Category 2, there is nibbling of uncovered skin with or without bruising hematoma. Just remember, in Category 2, there is uncovered skin, and in Category 1, the skin is still intact. Aside from that, for Category 2, there is a minor superficial scratches, abrasions without bleeding, including those induced to bleed. And all Category 2 exposures on the head and neck are considered Category 3 and should be managed as such. So what is the management for Category 2? You have to wash wound with soap and water, and you have to start the vaccine immediately, and then there is no need for rabies immune globulin. The third category is Category 3. There is already transdermal bites, wherein there is already puncture wounds with lacerations or avulsions, or scratches, abrasions with spontaneous bleeding. It could also be licks on broken skin or mucous membrane, and exposure to a rabies patient through bites, contamination of mucous membrane, which are the eyes, the nasal mucosa, anal mucous membrane, or open skin lesions. It could also be due to unprotected handling of infected carcass or ingestion of raw infected meat. Exposure to bats is also Category 3. And all Category 2 exposures, if it is located in the head and neck, are considered Category 3. So for Category 3, you have to wash wound with soap and water. You have to start vaccine, and this is the only category wherein we have to give the rabies immune globulin immediately. This table shows the history of tetanus immunization. This is the standard intramuscular regimen for post-exposure prophylaxis. As you can see here, you can give the immunization on day 0, day 3, day 7, day 4, and day 14 rather, and day 28 if you are using the intramuscular route. For this one, you have to give 0.5 ml if you are using the purified Vero cell rabies vaccine, and you have to place it in the deltoid in adults or the anterolateral thigh in infants. However, if you use the intradermal regimen, you have to use 2 sites, the right and left deltoids or the anterolateral thighs in infants. You have to use it on day 0, day 3, day 7, and day 28, and you will only use 0.1 ml. If you can see here, the difference between intramuscular and intradermal is there is no day 14 for intradermal, and aside from that, there is only 1 site in intramuscular and 2 sites for intradermal. Also, in intramuscular, you have to use 0.5 ml, and in intradermal, you have to use only 0.1 ml. But it has the same sites of injection. You have to complete the vaccination regimen until day 28 to 30 if the animal is rabid, the animal is killed or died without testing, the animal has signs and symptoms of rabies, and the animal is unavailable for 14-day observation. Like for example, if the animal is already a stray animal. However, you may not complete the vaccination, or you may omit the day 28 or day 30 dose for the following. The animal is alive and remains healthy after 14-day observation period. The biting animal died within the 14 days observation period. However, it is confirmed by the veterinarian to have no signs of rabies and is already FAT negative. So patients who have completed 3 doses, that is day 0, day 3, and day 7, are considered to have completed the pre-exposure prophylaxis. These are the rabies immune globulin. There we have the human rabies immune globulin, wherein we have to use 20 international units per kilo, and the equine immune globulin or FAB products, wherein we have to use 40 international units per kilo per dose. These are the guidelines for passive immunization or the giving of rabies immune globulin. A skin test should be performed prior to ARIG administration, and you have to read it after 15 minutes. If the induration is more than 6 mm, it has a positive skin test. Hypersensitivity to ARIG may not be predicted by skin test, so always be ready with epinephrine and antihistamines for treatment of hypersensitivity. And patients should be observed for at least 1 hour after injection of the rabies immune globulin. These are the guidelines for passive immunization. The rabies immune globulin should be administered at the same time as the first dose of vaccine. If rabies immune globulin is unavailable when the first dose of vaccine is injected, it may be given until 7 days only after the first dose of the vaccine. Beyond 7 days, rabies immune globulin is no longer indicated. You don't have to give it anymore, regardless of whether day 3 and day 7 doses were given. In the event that the rabies immunoglobulin and vaccine cannot be given on the same day, the vaccine should be given before the rabies immunoglobulin, since the RIG inhibits the development of antibodies from immunization. Here are the frequently asked questions. Will every person bitten by a rabid dog develop rabies? The answer is no. Only 15 to 20% of those bitten by the same dog will develop rabies. There is intermittent release of the virus in the animal saliva, so you will not know exactly who will develop the symptoms. When is the right time to administer treatment? Once bitten, you have to treat at once, depending on the category, because treatment is only effective during the incubation period, which is an average of 20 to 90 days, after which there is no cure for rabies. What is the period for observing the dog if it has rabies? WHO recommends observing the dog for 10 days. However, in the local setting, the national program recommendation is for 14 days. This is because if the dog has rabies, it will most likely die within 5 to 7 days. WHO extended it to 10 days to catch late deaths. A national recommendation extended it further to 14 days to catch unusually late deaths. How fast does the rabies virus travel? It usually travels at 3 mm per hour, although it varies in each individual. Are there cases when rabies was manifested late in a patient? The average incubation period, as was previously discussed, is 20 to 90 days. However, in 71% of patients, the manifestations are late, that is, sometimes within 1 month. In 87% of patients, within 3 months. It is shorter if there is increased virus load, depending on the severe exposures, and it also depends on the site of the bite location. In exceptional cases, the manifestations will occur after 6 years. Is pregnancy and infancy a contraindication to rabies post-exposure prophylaxis? No. There is no contraindication to administering rabies PAP in patients exposed to rabies. This is because the risk of rabies is greater in the mother than whatever teratogenic effect it may have on the fetus. What is the reason why IM route is used for private patients and ID or intradermal route for government centers? It is better and more economical to use the full dose intramuscular for private patients rather than just administering 1/5 or 0.1 ml of the contents, because of the unused vaccine will just go to waste. Is it okay to interchange brands and regimens, that is intramuscular to intradermal and vice versa? No, it is not advised. There is no study to prove that immunogenicity is maintained by doing this. However, there are certain cases when you will be forced to change brands. That is, when the patient lacks funds, then it will be under your discretion to do so. How do you manage a previously vaccinated patient who was bitten again? First, always remember local wound treatment. If the patient received at least 3 previous doses of pre-exposure prophylaxis or post-exposure prophylaxis, that is, they already have the vaccine on days 0, day 3, and day 7, that is already complete. So the booster doses can only be given on days 0 and day 3, and you don't need to give the rabies immune globulin. However, if the patient only received 1 or 2 previous doses of post-exposure prophylaxis and pre-exposure prophylaxis, that is still incomplete because it is only 2 doses. You need to give the full course of post-exposure prophylaxis, and the rabies immune globulin is still needed. Here are the guidelines if there is delay in consult. You treat as if the exposure occurred recently. If the biting animal has remained healthy and alive without signs of rabies until 14 days after the bite, no treatment is needed. For missed doses, you have to give due dose when patient comes and adjust the schedule of the subsequent doses. It is important that the first 3 doses are given within the prescribed interval. As previously discussed, you have to give it at day 0, day 3, and day 7. If the second dose is delayed by more than 4 days from the scheduled dose, the second dose is the first dose is day 0, the second dose is day 3. And that means if you miss the day 3 dose, that is after day 8 or longer, you have to restart the series. If the third dose is delayed, that the third dose is day 7, if it is delayed 8 to 14 days from the scheduled dose, you have to repeat day 3 dose and revise according to the prescribed interval. If the third dose is delayed by more than 14 days already from day 7 schedule, you have to restart the series. What are the guidelines for the bites by animals other than dogs or cats? You don't have to give post-exposure prophylaxis to mouse, rabbits, and guinea pigs. And you have to give post-exposure prophylaxis to monkeys, cow, pigs, and bats. For bites by vaccinated dogs or cats, post-exposure prophylaxis is not recommended for Category 1 exposures. Post-exposure prophylaxis can be delayed for Category 2 bites provided that all of the following conditions are satisfied. The dog or cat is healthy and available for observation for 14 days. The dog or cat was vaccinated against rabies for the past 2 years. And dog or cat must be at least 1 year and 6 months old and has updated vaccination certificate from a duly licensed veterinarian for the last 2 years. The last vaccination must be within the past 12 months. The immunization status of the dog or cat will not be considered updated if the animal is not vaccinated on the due date of the next vaccination. If the biting dog or cat becomes sick or dies within the observation period, post-exposure prophylaxis should be started immediately. The PEP should be given immediately for any of the following conditions. Category 3 exposure. The dog or cat is proven rabid or sick, dead with no laboratory exam for rabies. It is not available before or during the consultation. The dog or cat is involved in at least 3 biting incidents within 24 hours. and the dog or cat manifests behavioral changes suggestive of rabies before, during, or after the biting incident. Here is the pre-exposure prophylaxis schedule. So, you can give it intradermal or intramuscular. You have to give it on day 0, day 7, and day 28, or you can give it on day 21. But ideally, it is best to give it on day 28. You only have to give it 0.1 ml if it is intradermal and 0.5 ml if it is intramuscular, regardless of whether it is PVRV or PCEC. What are the benefits of pre-exposure prophylaxis? The need for passive immunization, that is the rabies immunoglobulin, is eliminated. Because if you already have a pre-exposure prophylaxis, if you are bitten by a cat or a dog, you don't need to give the rabies immunoglobulin anymore. The protection against rabies is possible even if the post-exposure prophylaxis is delayed. And the protection against inadvertent exposure to rabies is possible. And the cost of post-exposure prophylaxis is reduced. So it is always advised that healthcare workers and those who are exposed to dogs and cats should have a pre-exposure prophylaxis. Who should receive the pre-exposure prophylaxis? Healthcare workers directly involved in the care of rabies patients, individuals directly involved in rabies control, personnel in rabies diagnostic laboratories, pet owners and household members, animal handlers, field workers such as dog vaccinators or dog catchers, veterinarians and veterinary students, and children 5 to 14 years old living in areas where there is a high incidence of rabies, like in southern Tagalog. There is no need to restart series if doses are not given as scheduled. If a patient gets bitten while completing the pre-exposure prophylaxis, you will need to convert this to post-exposure prophylaxis. What are the routine boosters for high-risk individuals? First, for the general population, in the presence of exposure with animal bites, you have to give a booster dose on day 0 and day 3. However, without exposure, there is no more routine boosters. However, in high-risk individuals and all workers in rabies lab, you should also give boosters on day 0 and day 3 in the presence of exposure. Never use these things if there is an animal bite. Never use a tandok, which is always used in the province during animal bites. Never place a coin on top of the animal bite. Never place garlic. Never place stone. And most importantly, don't ever sock the wound, because this was the previous practice by Filipinos before. Thank you very much for listening. I would like to thank Dr. Mayan Lumandas and Dr. Joanne De Jesus for lending me some slides. Thank you very much. Please answer the post test and click submit. All for the Filipino child.